So we'll just go ahead and start. And of course, you all know this is what I do. It's the coding for local health departments, clinic, and school sites. And this is the September 2016 edition. I'm going to have a few changes, well, not really changes, but new codes that came out that will be coming out for the coming year for ICD-10. I know we just got used to the 10 issue, but we are going to move on and try to get some changes done too. So, but to be honest, I sent out a huge list of new codes, but the issue is that there's not a whole lot that's really going to affect us too much, but the ones that are there that are going to affect us, I'll go over those, and we'll make sure that those are in the right cost centers and all that good stuff. So, all right, so we'll go ahead and start. Of course, I go over my wonderful table of contents. So we're first going to go over coding on the PEF, the determination of new or established patients, the coding of preventive visits, components for coding other than E&M visits, which is what we call problem visits, coding of problem visits for new patients, and then coding of problem visits for established patients, multiple visits for the same patient on the same day. So these are all the things that we're going to go over. Also, I'm going to go over I think I've made one change to the PEF that we'll go over at the very end too. And I'm going to go over some ICD-10 codes that I think will affect you all a little bit, so that way you will know a little bit more about it. So, okay, and then I have to tell you, this presentation was done, hang on just a minute, I'm sorry. Okay, this is my slide basically telling you that this presentation was done for anybody walking in off the street, so that they can kind of have an understanding of how we do our coding in the health department settings. It's also a refresher for anybody who is not, who's been there for a while, but, don't really have it completely under wraps as far as coding, which, we can all use refreshers, right? So this is what this entire presentation is about. And of course, like I said, I am going to have a few new ICD-10s, just so you know. Sorry. Okay, we first go over our guiding principles. Only code the level of care that was medically necessary per clinical judgment. All RNs need to provide and document services in accordance with the CCSG and with established best practices. Always code and document exactly what care was provided. Hang on just one moment. Okay. All right, like I said, we're having a little bit of hiccups, but it's all user error. Sorry about that. Okay. Coding on the PEF, the state has an updated CH45 that we use in the health departments, which is the patient encounter form. We call that PEF, but it is the patient encounter form. We also have some health departments prefer to create an abbreviated PEF for offsite clinics, which is the flu clinics and the school sites. And this is entirely permissible. We like for you all to be able to use the forms the way that you need to use them, and if you need to change them, that we're all for that. The only thing that I ask is that you make sure that you keep them up to date, and you look at those annually. Each year you have to look at those to make sure that nothing has changed, or if it has changed, you're going to change with it. So just make sure that you keep those up to date. Okay, so now we're going to get into the nitty gritty, which is your codes and what they are. Okay, your CPT codes are your what was done for the patient. That's your what service are you providing for that patient. Your ICD-10 code is your why. Why was that done? What's your chief complaint when you came in? Then that's what's going to happen right there. That's what your ICD-10 code is going to be. Okay? So that's your why you're doing something for that patient. That's why you're doing your what, okay? Which is your service. I'll give you some examples of ICD-10, or actually of CPT codes and your ICD-10 codes. I'm sure everybody's pretty familiar with these. We have, first one is, of course, a brief office visit. Second one there, CPT codes, is your preventive code. So that's age 5 through 11, because your preventives, you're going to go based on age. So, and other things we'll go over in a little bit. So, and then your ICD-10 codes, they're, which I'm sure everybody's hopefully pretty used to, but, you know, if not, right there they are. Yay. We have the Z00.129, which is encounter for routine child health examination without abnormal findings. So there's something that you'll use quite a bit, I'm sure, for your preventive visits. Okay. Coding E&M visits on the PEF. Coding E&M visits in the health department clinics consist of basically two main things that you're going to be doing. You have your preventive E&M visits, which is your well child's, well woman checks. And then you also have the second option, which is your E&M visits, which is what the LHDs and what I try to talk so that you all understand me, is it's commonly referred to as the problem visits. Okay. And these are your supply visits, STD screens, cancer screens, anything, or even STD treatment. So this is where these come into play. But those are your two main visits that we basically do in the health department. Then we're going to go over where it is on the PEF. You have your preventive visits, or your well child exams and well woman exams, which is in the top left corner of the PEF. Your E&M visits, which is on the top corner of your PEF. We also need to remember that coding on the PEF and the providers, hang on just a minute, I'm sorry. There we go. Okay, sorry. All right, coding on the PEF and the provider level. Remember that the 992 codes are for use by physicians and mid-level providers only. The W92 codes are for nurses. That's your RNs that are using the codes out there. So that's why we have those W codes, is for RNs. This is one of those things that usually throws a lot of people off, because in the real world, nurses are only allowed to code to a 99211, which is a brief office visit, and that's it. Our contract with Medicaid allows RNs to code higher. So we're going to go over all of that. So just know that we're going to do all that. So just hang on. Coding on the PEF. CPT codes. You also have, I'm telling you where everything is basically on here, just because, like I said, this is for anybody walking in off the street, so that they know what's where and all that good stuff. So you have your labs that are right underneath your preventive visits on the left side, and those are your procedures right there. There's procedures, and then there's also laboratory tests right underneath of that. If there is something on the PEF that we do not have listed, which I try to get as much as we possibly can on this PEF, but you know, there might be one or two things that we don't have on there. If that's the case, flip it over to the back, and you can add it in on the write-in section on the back. All right, now coding on the PEF with the ICD-10 codes. The reason why I'd go over this is because it's easier for the girls in the front, or any kind of, or not, I shouldn't have said that, for the clerks in the front that actually are inputting this information in the system. It's easier for them to know what goes with what on this. Okay, so that's why we're going to go over this. The ICD codes need to be written on the PEF in the section that corresponds with the service that was provided. So when you're doing a preventive, if you look in that top left-hand corner of your PEF, I hope everybody has a PEF. If you look in that, then you can actually see there's a place for ICD-10 codes on the side there next to your preventives. So you actually can see, oh wait, this provider has done this, and we need to put this ICD-10 next to it. So for that reason, that's why you're doing that, because you want it to actually show it right there next to it. Okay. The ICD-10 codes will reflect why the patient presented, which is your chief complaint. They are assigned based on the presenting problems of the patient, or rather, chief complaint, like we just said. For the primary ICD-10, please, what I would do, because like I said, there's a lot of information on this PEF, and it's hard to get everything on it, but use it how you need to. But I would circle the primary one, just because I would want my clerk up front to know that this is where I want this to go as far as cost centers. Okay, so that's what I would do, is just circle the actual ICD-10 code that you want that to go to, that visit to go to, because as you all know, it's only the first ICD-10 code that it takes it to the cost center. So let's just remember that, and just go ahead and circle whichever one you're thinking it should go to. Okay, so, and like I said, there's your example of it. I tried to circle, but it didn't work so well when I did this, so just so you know, that should be circled. That's why I put on there, circle the primary ICD-10 code. It's just easier for the clerks, to be honest. Okay, so let's go into this. The ICD-10, yay, it's here to stay. I don't know if you all like it or not, but it's what it is. It's a lot more in depth, I'll just say that. But it is here to stay. And the ICD-10 codes, the changes will begin as of October 1st, 2016. Now, I know on the email that I sent out with all of the PowerPoint and documents that I sent out, I actually had 2017. That was my mistake, and I own that, and I'm sorry about that. But it should be October 1st of 2016. So, and I did actually issue a correction, because I just wanted you all to know this is actually, it is going to happen as of October 16th. Okay. No, did I say October 16th? October 1st, 2016. I will get it right, I'm sorry. Okay. And then, of course, I'm sure you all have lots of lists out there, because I kept telling everybody. I mean, I said this for probably 5 to 6 years before ICD-10 happened. I wanted you all to go through your list and actually update those with the correct ICD-10, so that your 9s actually just replace, the 10s actually replace the 9s. So just remember, this is going to start changing as of this year. So just make sure that you look at what you have on those lists and update them as needed. Okay, with that being said, there is actually a code out there now as of October 1st, 2016. They actually developed a code for Zika virus disease. Now, I don't know that you all will be using this code out there. I'm not sure if that's the case, but I'm wondering, I have a feeling there's probably one out there for the testing of it too, the screening of it, but I didn't have a chance to really look into that, but I'm going to. But that is A92.5 is your Zika virus disease code. Like I said, that's brand new for October 1st of this year. So we also have some others listed here. That is your encounter for prophylactic immunotherapy for RSV. Okay, so that's the Z29.11. We did actually have just the Z23, but these are actually specific to which immunization you're actually giving. So just know that these are kind of, and like the rabies vaccine is right here too. That's the Z29.14. So just remember that these actually, there are a few that are specific. We used to, on the others, we actually have been using just the Z23 dot, but they actually got specific on these and wanted to put these in here, I guess. I also have encounter for prophylactic measures unspecified. So this might even be something that you could use for like the patients that come in and you talk to them about vaccines, but then maybe they decide, hey, I'm not getting that, no, or something like that. If that's the case, then maybe you could use this one where it's unspecified. So just know that there's a whole lot of information here. So, but we'll go over all of that. And like I said, there's lists out there that I sent out so that you all can actually look through those. Now, these are the ones that I actually wanted to go over with you in depth because these are family planning ones. And Benita is actually our family planning program coordinator, I think, right now for family planning. And she thought that these actually looked pretty good. So we'll make sure that these are linked to the cost center of the 802, which is the family planning cost center. So, but this is, like I said, these are all here. This is the Z30.015. This is for encounter for initial prescription of vaginal ring, hormonal contraceptive. Excuse me, if I could talk, that would be good. And then we also have the patch there. We also have initial prescription for implantable, which you all know what that is. And then your vaginal ring, hormonal contraceptive device. There's all kinds here. There's just all kinds of stuff that you can actually look into on this stuff. So, okay. So, like I said, we'll go over that list that I sent out. I want you all to look over that and see just to make sure that those are on your new list that you're currently using. So, all right. So, determination of new or established patients. We'll go into that. I have to tell you where that is on the PEF, of course. Because on one side where the red is, that's new patients. On the blue side, that's established patients. So you have coding for new and you have coding for established on either side. So just remember that. And that's the first thing that you're going to go into actually talking to a patient. You're going to figure that out first. So like I said, we'll go into all that. New and established patients. A new patient is a patient who has not received a professional service at any health department or satellite clinic site in the county within the past 3 years. So, this is not based on a district, okay? It's county basis. That's it. So, if they have not been seen in that particular county, then they are technically new. If they have not been seen in the past 3 years. Let me expand on that a little bit there. So that's the thing that you have to continue to remember. And to clarify, WIC is not a clinical service. So you want to make sure that it's not WIC that you're looking at to see if they are a new or established patient. Okay, with that being said, our system, meaning Portal and Bridge, or as CDP likes to call it, CMS, Clinical Management System, because I'm sorry people, but CMS to me is Medicare all day long. So, but anyhow, it's Clinic Management System, and it determines whether the patient is new or established at the computer registration when the PEF label is created. So this is one way that we know we can look at and see if that's actually right or not. I have tried to prove them wrong, I'll just tell you, but it's not easy. So just make sure that that registration label that comes out is actually saying new or established on it, and that you agree with it as well. So the computerized registration process is generally not done in the satellite clinic site itself, often making it difficult for providers to know whether the patient is new or established in those sites. And by the satellite clinic site, I'm talking about like your school sites, that type of thing. Because it's not easy to know unless you have that label. So we're going to go over how to do that. If the provider cannot determine whether the patient is new or established by looking at the medical record, the provider should check the appropriate new patient level of visit and the appropriate established patient level of visit on the PEF. I'll show you an example in the next slide. But it's one of those things that it's better to look at it now than later, and just decide for both cases. That way you don't get that PEF back from that clerk asking, hey, what is this? Is this new? Is this what wait a minute, this is actually an established patient and you checked for a new patient, so that's something you need to think about. And why I'm telling you this is because I'm trying to save you time so that you don't have to look at this PEF again. So, and that's what I'm saying in that second sentence there, is that, I would rather you look at it now than later on. And it's fresh in your mind too. So here is an example. Now, just keep in mind that I listed this and it was easier to highlight that whole row and just put check marks on it, but that may or may not be the right check mark place, because normally when a patient presents to the nurse requesting a pregnancy test, if it is a positive pregnancy, that is going, if it's an established patient, that's always going to be an expanded. So just know that. So this is just me saying, hey, just remember to check both if you can't tell which is what. The other thing that I need to make sure that you'll understand is staff doing data entry should look at the label to determine if a new patient is established, then enter the correct office visit and mark through the other visit. So that's the only thing that clerical staff can do, is mark through the incorrect visit. They cannot pick a level. So just something to think about. And also, let's remember that for when the actual clerical staff is bringing it back to the nurse or APRN or whoever, the actual provider. This is me just saying one more time, under no circumstances should staff entering data change the level of visit to accommodate a new or established patient status, unless that level was also marked on the PEF as discussed in the previous slides. Okay, so this is why I'm telling you all, make sure that you go on. If you can't decide whether or not that is a new or an established patient, then make sure you do both of them. So that way you don't have to see it again. Because let me just tell you, the clerical staff is not allowed to pick a level of visit. They're not allowed to do that. That is beyond their scope. The provider must determine the level of visit. So just remember that. So when they bring that back to you, basically it's because I'm telling them to. So you can yell at me if you want, but don't take it out on them. It's better if you come at me. So, but they're not allowed to pick that visit. Okay, coding of preventive visits. Preventive visits are reported when the patient receives a full preventive physical exam per the guidelines in the CCSG, or the Core Clinical Service Guidelines. That's a mouthful, I'm sorry. The CCSG. So, coding of these visits require three main components. You're first going to check to see new or established patient status, the age of the patient, and then, of course, the completion of the physical exams by protocols, which are listed in the CCSG. So that's basically all there is to when you're actually coding for the preventive exams. Like I said, there's not a whole lot to it. It's mainly age, and then, of course, determination as to whether or not those are, if you've met all of the exam components to that. That's the main thing that you're looking at there. Okay, now, components for coding other than preventive E&M visits, which is what we call the problem visits in the health department setting. So, problem visits. Let's get into it, right? Problem visits are made up of three components which are directly linked to the coding of these services. History consists of a combination of three parts. You have history of present illness, review of systems, past family and social history. And then the second component is exam. And then the third component is decision making. These three components are the driving forces behind the coding of problem visits. You have to understand these three components to accurately code for problem visits. Okay, let's go ahead and we're going to go into all of these so that we know what we're talking about here. History. And I like to compare it to what nurses call SOAP notes. So you have your subjective documentation that is reported by the patient. Like I said, I'm trying to refer it to stuff that you will know about and are aware of how you document. So that's your subjective portion of your SOAP note. Okay, this is where all of your history comes into play. It's a combination of three components: your history of present illness, your review of systems, and your past family social history. Then we go on to exam, which is your objective, what the provider notes when assessing the patient. The exam is comparable to the O portion of your SOAP note, the objective, and this is where you're going to document your exam. Okay? The exam portion will be discussed in detail on the coding of problem visits new patients section of this presentation. So this is something that I want you all to know. I'm going to talk about it in major detail when we get to this portion. Okay, so just hang on to your questions, and if you have questions, please go ahead and write them down, and I'll go over all this at the end. The decision-making component consists of three parts. This is where your presenting problem management options are going to be put into what I compare to your assessment portion of your SOAP note. Okay, that's your A, your SOAP note A. So it's assessment. After looking at the patient history and performing an exam as needed, the assessment of what the patient's problems are, that's where this is going to be. Then you have two more components for decision making. Like I said, it's a three-parter. You have diagnostic procedures ordered, and then this is where your provider must decide if any diagnostic procedures should be done and what they are. And then also, number three is management options selected, what treatment the patient should receive. And this is where your P comes into play. That's your P plan portion of your SOAP note. Okay? I know. So, We're going to go straight into coding problem visits for new patients, because let me just tell you, it's different. New patients and established patients, coding is different. The AMA, the American Medical Association rules require that you implement some of each of these components for new patients. So if you have a new patient, you have to have a history, an exam, and a decision making. All of those three main components have to be shown in your documentation for a new patient. The AMA rules state that you must code other E&M office visits for new patients to the lowest of these three components. By lowest of these three components, they mean the component which has the least impact on the visit. Okay? So I'm gonna skip over that at the bottom, because I don't want you all to be able to do that, because I want your documentation to have all three there. But if you don't have that, then you can refer back to this and put in the 80,000 code. But like I said, we're going to go over this so that you don't do that. So what I was saying is that the AMA actually requires that you code to the lowest thing that you're doing. Okay? And I have looked at, I don't know how many charts in my lifetime, but, well, actually, and here, I've been here for 8-9 years now, I think. And I've looked at umpteen charts that we have, and exam is always what gets us on new patients. So 99.9% of the time, exam is going to be the lowest component for new patients. So the reason why I wanted to explain that is because new patients should be actually coded to the amount of exam that is performed. And this is commonly referred to as exam bullets because of how they are identified by CPT classification. Okay? So this is what I'm talking about when I say exam bullets. Okay? Is the amount of exam. And this is, again, on new patients. AMA has determined that all providers have to code to the lowest component of the visit, which, like I said, in health department settings, exam is what gets us every time. And I've looked at umpteen charts. I'm serious. There's just only so much you can do, but the exam is what's going to get you. A complete list of exam bullets can be found, and I show you where you're able to find that. If you need help on that, just send me an email or send the help desk an email, and we can get that to you. So now that I've actually stressed the exam issue on new patients, just remember, you have to have some history, some decision making, but exam is where you're going to code. So that being said, I'm giving you the 5 most common bullets. Okay, this is actually something that you can look at and just basically, you don't have to touch on too much, but you do just a teeny bit, But it's just, you can actually observe these actual exam bullets from just looking at them, to be honest. You have your general appearance and nutritional status, and just so you all know, on the H&P 13 and 14, these are on different lines. They should not be, because, well, they can be for purposes in the clinic. However, for coding, they should be on one line because they're only one exam bullet. The mood and effect, orientation, and then on skin, you can actually get 2 bullets. You have your inspection and palpitation. So that's your warm, pink, and dry. I mean, that's actually 3 that I listed there, but it's actually only 2 bullets because I said pink and then dry and warm. So that's actually, I'm using 2 of the bullets for skin on that. Now, that's your 5 most common bullets. Now, if you add 3 vital signs, because With vital signs, it is a 3-for-1. Okay, so you have to have 3 vital signs in order to get 1 exam bullet. Okay, so when I list your vital signs there, that's not all of them, of course, but it's one of those things that I ran out of room. So that's what I could fit on that. So it's a 3-for-1 though. Just remember, vital signs, you have to have 3 vital signs to get 1 exam bullet. Okay, now that I have gone over with you exactly how you're going to look at your coding for new patients, I'm also going to tell you how to code it, because it's pretty specific in the AMA guidelines on the level of coding for new patients. And it actually lists out 1 to 5 exam bullets is going to be a brief. 6 to 11 is your expanded. 12 to 17 is going to be your detailed. Then you get into 18 to 23 is comprehensive, and 24 or more bullets is going to be your complex. Let me tell you, if you're doing that much exam on these patients, usually you might want to look at flipping that over to a preventive exam unless they've already had that this year, okay, by their normal primary care physician, okay? So that's what you want to make sure of before you actually code a preventive. You want to make sure that they have not had one of those in the same year, okay? Because if you do code a preventive and they've already had one with their primary care physician, then you're not going to get paid for that. So just remember that. That's one of those things that you kind of have to keep in the back of your mind. I'm hoping your billing staff would be able to help you more with that. Okay. But then we go into, just so you know, AMA expects medical providers to do a more thorough exam within reason on a new patient to provide a good baseline for future visits. And I even give you a KAR there. But that's the whole thing, is that just remember that when that patient comes back, they're no longer a new patient at that time. So you have to know, well, what were they like when you first saw them? You know, so that's why you have to kind of have a little bit more information on them. Remember, I'm trying to just get it in your mind that you're thinking how to code for new patients. New patients. Remember to have some history, some decision making. However, the coding for new patients is directly related to the amount of exam bullets performed, as it's usually the lowest component in the health department. Count the number of exam bullets and code accordingly. Now, what I have to go over here is DPH policy. According to the coding criteria for coordinated health, school health, APRNs, and/or registered nurses may code one of the following codes for new patients: 99201 and 99202, W9201 and W9202. Count the amount of exam bullets provided as medically necessary and code one of the 4 permissible billable codes listed above. But like I said, you know, it's one of those things that this is DPH policy. Thanks. Coding for preventive visits. Excuse me, I said preventive and I meant to say problem visits. I'm sorry about that. For an established patient. So now that we've gone over new patients, we're going to go over established patients as well. Because let me just tell you, the coding for established patients is different. To code a problem visit for an established patient, the AMA requires that only 2 of these 3 components be documented. Meaning you have to have some history or some exam or some decision making. So you have to have 2 of the 3. Now, the AMA again tells us, whatever you do, you still have to code to the lowest of what you do. That's just the way the AMA works. So, The level of visit chosen for established patients will be driven by the lowest of either the history component or the medical decision-making component. Exam performed should be what is required by protocol and medically necessary. Okay, sorry about that. Now, we're actually going to dive into the established patient clinic, the problem visits for established patients clinic. And the best way I think I have determined on how to do this is to give you all examples. I think that in order to learn, it's easier to just know by example, I guess you could say. So that's why I kind of give you the examples at the bottom, so that you kind of have an idea of what I'm thinking as far as with coding and how you should be at what level and that type of thing. So on established patients, because like I said before, you only have to have 2 of the 3 main or the key components, which is for established patients on a brief, no history is really taken. Decision making is minimal. Systems, this is a very small, minimal visit, okay? The example I give you is negative TB skin test reading, where you look at the arm and you go down the arm and it's fine. This is your one-liner in your notes, okay? Never write a soap note for negative TB skin test reading, because that will raise the level of visit and it's never medically necessary. So you don't want to do that. It's just your one-liner in there, have your 0 there if it's a negative TB skin test reading, okay? So it's a very simple visit, I guess you could say. Very minimal. Okay, and then we go into limited for established patients. This requires, again, 2 of the 3 key components, which is your problem-focused history, straightforward decision-making, problem-focused exam. This is basically your patients who have 1 or more self-limited or minor problems. I give you an example below for this level of visit. And the first one is a supply visit with no complaints, no problems. She's just coming in, or she is coming in and saying, I want my birth control. And they are not having any issues with it, they just want it. That's where this is going to stay, is your supply visit. You also have an STD screen with no problems or negative results. Okay? So that's where they're coming in and saying, I just need to be checked, because I don't know what's going on, but I've heard so-and-so or what have you has this, and I just got to be checked. So that's where your STD screens are going to come into play, is at a limited level. Also, head lice, either suspected or found, because you can't really do anything for that head lice other than send them home and tell them to get a kit of some sort to treat it. But that's essentially what you can do. So that's why that has to stay at the limited level, because you're not doing a whole lot of case management for that. Now, we're going to go into the expanded for an established patient. This requires, again, 2 of the 3 key components: expanded problem-focused history, expanded problem-focused exam, decision-making of low to moderate complexity. Now, this is where your patient comes in, wants to receive depot. She's had a little bit of a gain since she was there last. She has an occasional headache, but not that big a deal. I still want my depot. But you talked to them about it, you counseled them, and you actually decide, okay, well, we will go ahead and administer the depot. That's where your expanded problem is going to come into play there, okay? So you used a little bit of your case management, but you decided that since it wasn't that big of a weight gain and she has just an occasional headache, it's not that big a deal. So you're going to go ahead and give it to her. If that's the case, then you're going to code to the expanded level. Also, positive TB skin test readings would be at this level because we all know that we do a whole lot more for those patients. Positive STD visit with treatment is where that's going to come into play as well for your expanded visits. Okay, this is when you're actually treating an STD. So, or a positive STD. You know, that's the whole thing, is that it's a positive. It's not a negative, it's a positive. Negative is going to be back at your limited level. Positive is going to stay at your expanded. And then we have the detailed level, which, of course, like we have said in the past 3 examples, requires at least 2 of the 3 key components. So you either have to have a detailed history, a detailed exam, or a decision making of moderate complexity. Presenting problems are moderate high complexity. This is where, and I give you your examples, of course, you have a true contraindication to contraceptive methods. Okay, this is where she wants OCs and her blood pressure is 160/92, and she is complaining of severe headaches daily with visual impairment. No contraceptive is given until the patient is further evaluated. Okay, so this is one of those things where you're referring on to someone else. Okay, and I would think you would send this on to like an OBGYN. And if that's the case, then that's where you're going to code, is at the detailed level. Okay, because if you're sending her back to her OBGYN and telling her, hey, you've got to go get checked out, something's not right, you know. So in your mind, your case management went up for that reason right there. Okay. So, and then also you have patients presenting with problems of significant enough or more case management is necessary. Patient with an abnormal breast exam. These are one of the things that you're going to refer on to like a surgeon, or if you're, you would refer on to someone else, a higher specialty physician of some sort. So that's why this is going to be at the detailed level. Now, I say all this, but I want you all to know that if you don't do stuff, it will not be paid, okay? And I want you all to make sure that you're documenting everything you're doing so that you get the reimbursement that you need in order to stay open. So make sure you document everything you do with a patient if you actually code to a detailed level. So, and I put this at the bottom, just so you know, this is not our Medicaid. This is physicians' Medicaid that only pays doctors for 2 of the detailed visits every 12 months. So just remember that. This is the physician's Medicaid I'm talking about. It is not our preventive Medicaid at this time. But I just want you all to know that if you're going to code to this level, make sure you have everything documented. Now, I actually go into another detailed visit here because I want you all to know, I want you all to have a little more example than what I just gave you too. And this is where your positive pregnancy test initial PN visit. Okay. Now, you already know she has a positive pregnancy test, so she already has a problem. Okay. The problem, now some people don't look at it as problems, however I do. Just so y'all know, I have twin boys. So it's a positive pregnancy test is a problem. Whether you want that child or not, it's still a problem. Now, in order to move on up that chain of actually being a detailed visit, you would have to look at this patient and see if she qualifies for a high-risk pregnancy, which includes 2 or more risk factors. And I show you some of those risk factors below. That would be like your history of miscarriage, high blood pressure, early labor, preeclampsia, STI with pregnancy, or STD with pregnancy, however you want to say that, your smokers, obesity, and then your age, over or under. So all these are risk factors. If you have 2 or more of those documented in your notes, then you can code to the detailed level. And also, I just wanted to make sure that you all know that if you're referring to an OBGYN, make sure that you actually list OBGYN and not Dr. So-and-so down the street. You know, because an auditor's not going to know who Dr. So-and-so down the street is. So just remember that you need to make sure that you list their specialty. Then we go into comprehensive, which is, again, on an established patient, you have to have 2 of the 3 key components in your documentation. So you have a comprehensive history, comprehensive exam, decision making of high complexity. Presenting problems are moderate to high complexity. Significant risk to the life of the patient. Now, I'll give you some examples because I want you all to know that this is going to happen here. The examples I start with is HIV, because you know you're going to go over a lot of information, a lot of counseling, a lot of everything on that. And also rape. That's another one where you're going to have lots of counseling, lots of in-depth conversations, lots of everything. Abrupt neurological changes. Like I said, there's going to be issues. So with that, that's going to make your case management go significantly higher. Make sure you document everything. Anaphylactic reaction to vaccine. And then, of course, emergency treatment necessary via EMS. So anytime an EMS person comes in to get that patient, think about what you did to keep that patient in, I guess, standing up or, well, laying down or whatever. Whatever you did in order to save that life, you need to document it. And you're basically the only thing that's hanging on to that patient until that EMS provider gets there. So just remember that. That's the reason why you're coding to this level. So remember everything that you did in order to keep that patient alive, okay? Or keep them whatever, you know. So just remember that and document it. Make sure you document it. Now, I have to put this at the bottom, just so y'all know, it's not our it's physician's Medicaid, it's not our Medicaid. That is not the preventive Medicaid, okay? We use the preventive Medicaid, but doctors only get paid for 2 of these comprehensive visits every 12 months. So just something to keep in mind. Make sure if you're going to code to this level, you have documented, okay? Then I have to go over, this is our school, this is DPH policy. 99211 and W9211 is brief, no history taking, minimal decision, low severity, acuity, no review of systems. These are patients that have simple, self-limited, minor problems according to the coding criteria for coordinated school health. I give you your examples below. And then we also have, because in the school setting, you only have 2 codes for established patients that you can pick. Or rather 4, sorry, if you're an APRN. If you're an RN, you have 2, which is the W codes. If you're an APRN, you're going to have 2, which is the 99 codes. So, according to DPH policy. Limited requires at least 2 of the 3 key components. Again, like I said, when it's established patients, it's always going to be 2 of the 3. Then you have your problem-focused history, straightforward decision-making, complex or acuity, severity or acuity, problem-focused exam. This is patients that have a more complex self-limited or minor problems, according to the coordinated criteria for coordinated school health. So, and again, I list your examples below. So, Just remember, if it's more complex, this is where you're going to code for an established patient, according to DPH policy. Now, multiple visits for the same patient on the same day. Multiple visits for the same patient on the same day with a different problem in the clinic setting. A 25 modifier may be reported with a preventive visit if there is a significant enough or separately identifiable problem. The 25 modifier would be listed with the problem-focused E&M visit, not with the preventive, the actual problem-focused E&M visit. When immunizations are given, this is, like I said, I'm going to just go straight into my examples because I want you all, it's usually easier for you all to learn if I can actually show you my examples that I have. But let me tell you where it is on the PEF. You know where your problem visits are on the right-hand side of the upper corner? The 25 is in between the 99 codes and then your W9 codes. So just remember it's right there in the middle there. Now, let's go on into our examples. 39-year-old established patient comes in for family planning, preventive visit. While doing this patient's family planning preventive visit, the APRN finds vaginal warts and, with the permission of the patient, treats. Your coding would consist of 99395 for her preventive visit, and then they would also code the 99213 because they actually are treating an STD, and this is actually with treatment. And then you would put the 25 on that actual E&M code so that they can actually get paid for both, or it should be. So that's why you would code it that way, because you have a separate, identifiably different problem, which would be those warts that are there, and you're treating them. So that's why you're coding to the expanded level with the 25. Now, let me give you another example. Another example of when to use the 25 modifier clinic is this. 17-year-old established patient comes in for family planning supplies, and the RN finds out she has not received the Gardasil vaccine, or even whatever it is called now. I think it's the HPV-9 maybe. Patient wants to receive this vaccine and it's counseled per component. The coding on this would consist of, because she's coming in for her family planning supplies, right? She is coming in for that, so she's actually going to have her W921225 for the family planning supplies. But if you don't add that 25 onto that visit, the payer usually will not pay that visit because they see an administration and a vaccine, and that's it. And nowadays, as of, I think it was 2011 that they changed that, you cannot code an office visit with the administration of a vaccine. But because she was coming in for something completely separate than the immunization, you can code this like this. I'm not sure if the payers are paying it like that, but I'm hoping that they are, because this is correct coding. So it should be the W9212, which is your limited visit with the 25 modifier, and then your 90460 for the administration of the vaccine, and then the 90651 for that's the HPV-9. So just something to think about. Now, and I actually told you at the beginning that I had one change that we have added to the PEF, and I'm not sure if it's on the website yet or not, but I'm hoping that it will be soon. But we actually added the J7297, which is the Loletta IUD. That's Joy actually told me about this, and Joy Hoskins, sorry. And we have added that to the PEF so that if you're using this, you can actually code this now on the PEF. So it has been added on there just in case you needed it. And like I said, there's a whole lot of information on this PEF, so, but that's the main change that I did for this year. So, but I figured you all had enough changes with the ICD-10. I wasn't going to try to confuse you anymore. And since our codes didn't really change too much, I thought this is the main one. I just wanted to add it on there just in case you do need that. So, okay, now that we're done, I'll go over our guiding principles one more time. Only provide the level of care that is medically necessary. All RNs need to provide and document services in accordance with the CCSG and with established best practices. Always code and document, and then document one more time exactly what care was provided so that you get paid for the service you're doing, just so you know. And then I give you where I find all this stuff. And I don't think I didn't actually add my revision of the 2017, sorry. So, but if you have questions, that's where you can send them.